Hi, good morning. This is the fourth webinar from the Medical Society of Virginia in response to the COVID-19 pandemic. The Medical Society is working tirelessly to communicate all the relevant information related to COVID-19. And this can be found online at msv.org/COVID-19. My name is Clifford L. I'm the President of the Medical Society of Virginia. And prior to starting, I'd like to mention this is for CME purposes, and this is a specific statement I have to read, sorry. No commercial support was received for this activity. There are no reported conflicts of interest for any individual in a position to control the content of this program or speakers presenting in the program. We are recording attendance and will submit to VCU for CME credit following the webinar. VCU will issue a certificate to you at the email you registered with. Unfortunately, Dr. Jabari at the Virginia Department of Health had to cancel at the last minute, but we have two great speakers today, possibility of a third, Scott Johnson and Karen Remley. Scott Johnson is a partner at Hancock Daniel and Johnson and a longtime general counsel for the Medical Society of Virginia. And Scott is one of the best lobbyists in the Commonwealth and knows more about healthcare law than just about anyone, really, because I think he wrote most of it. Karen Remley is a pediatric emergency room physician, former state health commissioner in the Commonwealth of Virginia. She is the former CEO of the American Academy of Pediatrics and former chief medical officer for Anthem. She is helping the Virginia Department of Health in response to COVID-19, has been engaged at all levels of government in the Commonwealth's response. So first, I'd like to start with Scott. Scott, could you please explain some of the executive orders as they've been handed down by the governor, how they relate to physicians, specifically those on elective surgery, and how the stay-at-home order affects doctor visits? Scott?
Sure. Good morning. So the declaration of the emergency was Executive Order 51. And in that order, the governor authorized the launching of Virginia's emergency plan. And that plan was contained in Executive Order 42 that he had issued some time back. That's a very long, elaborate plan. And within that document are certain provisions that relate to liability. And I think it's a good place to start to realize that sometimes the liability is addressed if a healthcare provider is being asked to come and volunteer, meaning they're not being compensated for their time. And then we've got some other statutes to talk about if the situation is that the healthcare provider is being compensated. Most of the protections, whether you're a volunteer or you are being compensated, address what we call simple negligence. You would think of it as a garden variety medical malpractice case, a misdiagnosis, an inadvertent cut of an artery, those type of cases. Immunities generally do not apply to types of cases in two other categories. The first category is called gross negligence, and the second category is willful misconduct. We rarely see allegations of those in Virginia, fortunately, but examples of gross negligence could be that a obstetrician was called by the L&D nurse because he had multiple decelerations and just chose not to come in or didn't answer call, or someone saw some aspect of infection and just chose not to do something. It requires some element of intent. Willful misconduct does as well. So when you think about our medical malpractice cap in Virginia, it applies to actions of simple negligence. But if a physician were to commit an action that would be deemed gross negligence, the medical malpractice cap wouldn't apply. So as the governor was considering for COVID-19, by triggering the Virginia Executive Order number 42, where the emergency plan is, that resulted in triggering protection for volunteers. And basically in Executive Order 42, it says that if a healthcare provider holds a license in another state and comes to Virginia to provide care without being compensated, they are able to get their reasonable expenses paid. So if they have to stay in a hotel or have food or something like that, that doesn't contaminate the liability. But if that person comes without compensation and provides care, then they are immune from acts of simple negligence. And that has been the general theme that we've used for a long period of time. Many of you have heard the term Good Samaritan statute. It's very similar in that regard. Stepping away from the situation where somebody's providing care and not being paid and moving over into the situation where someone is providing care in our state, We have two statutes on our books. One has been with us since 2003, and then the General Assembly passed the other one in 2008. And those two statutes address situations that commonly can occur, and that is if a healthcare provider owes a duty to a patient and that provider is not able to deliver healthcare and has to leave and go respond to a declared emergency, then that abandonment, if you will, of the patient that you owe the duty to, you would be immune from liability for that for simple negligence. Again, not gross negligence and not willful misconduct. So for example, a physician is scheduled to see 20 patients in the office this morning. That physician has to leave those patients and respond to some aspect of COVID-19, and one of those patients has a heart attack right there in the office and dies. That statute would be triggered to come back and say that the physician could not be sued for simple negligence. The second statute that was passed in 2008 basically addresses healthcare providers that are delivering or withholding healthcare as part of a declared emergency or disaster like we're in now. So if you have to respond somewhere and deliver healthcare, you're protected. If you have to respond somewhere and withhold healthcare, meaning you've got 10 patients and one ventilator and you're having to decide how that works, then you've got statutory protection. So those are some of the things that we've been looking at, have had outreach to the Attorney General's office, to the Hospital Association, to medical malpractice insurance carriers, still trying to look to see if Virginia has got adequate liability protections. So Dr. Deal, I'll pause with that. Sorry, Dr. Deal, I couldn't hear you. I'm not sure if you were on mute.
Sorry, yes, I was muted. Sorry. So on some of the calls with BDH, we have heard the term crisis standards of care. Is that what this is talking about?
Well, the standard of care in Virginia is set forth in our Medical Malpractice Act in 8.01581.20. It's a statewide standard of care. And the question becomes, when you are in a disaster or an emergency, is there a crisis standard of care, meaning you need to do what you can in that situation as a reasonably prudent practitioner would. Our crisis standard of care is not extremely fleshed out, and that has been a subject of a lot of discussion. But basically the thought is, if you can get immunity or liability protection for acts of simple negligence and you're doing your best, that should be the pathway to address it. I would imagine after this disaster passes us that there's going to be more attention given in our Code of Virginia and our General Assembly to putting in statute how we're going to deal with a crisis standard of care to better delineate it.
Could you talk about how the executive order affects elective surgeries?
Sure. So the order that came out regarding the elective surgeries has had some interesting ways that was phrased, and it's given itself to some interesting interpretation. But basically how the order is phrased, it basically starts out with the general prohibition that you cannot provide procedures or surgeries which require personal protection equipment. But if the delay of providing those procedures would cause harm to the patient or affect their outcome or lead to disability or death, you can do this. There are some exceptions to that order, but basically the genesis behind it was to conserve PPE. And it's a judgment decision. The governor did not try to take away healthcare provider judgment. We've recommended that it's good practice that if you are presented with a clinical situation and you think you need to go ahead with a procedure, to get a second opinion. I know some hospitals require, if you're going to go forward with a procedure, that the chief of surgery needs to sign off or someone else. The key thing in all of this is documentation, making sure you're documenting what you consider the pros and the cons and why you went forward with what you did. And that order is in effect until April the 24th. There's been a lot of discussion in the last couple of days with the governor's recent executive order number 55. That had a longer time frame that goes to June the 10th, but this order that was issued, number 2, public health emergency, the effective date is April the 24th.
Thanks, Scott. Could you affect how the stay-at-home order affects doctor visits?
Sure. The stay-at-home order, that is Executive Order number 53, basically enables somebody to be able to go out and get necessary things. Medical care is specified in there. So I think we have seen many physician practices decide to say, unless it's absolutely necessary, don't come to the office. More care is being given through phone calls and telemedicine to try to make sure we don't have a situation where somebody is ill that comes to the office, and really encourage a reduction in interaction and more use of the iPhone, the telephone, means of that nature.
Thanks, Scott. We had a webinar last week on telehealth. Could you just give us any guidance you might have about how to the documentation and payment for reimbursing telehealth from DMAS and commercial payers?
I know when we had the call, the chief medical officer was with us from DMAS and made clear how the provider memo that came out on March 19th talks about the payment mechanism, and I would really encourage you to follow the process. I've seen as recent as yesterday that the Family Physicians, American Academy of Family Physicians, put out another coding update that dealt with Medicare as opposed to Medicaid. But I think and on the commercial side, the Medical Society has gotten some additional information from Anthem and some of the other providers. So it is very much laid out in the rules, and the best thing that we can recommend is follow that guidance. There is a great tenor and tone of flexibility, but you still got to code it right. You still got to document it as you go.
Scott, what has the Bureau of Insurance done so far to help patients and providers?
The Bureau has encouraged and has been working closely with the professional liability insurance carriers, the companies that provide medical malpractice, encouraging them to be very lenient in renewals, be lenient in renewal premium payments. And to the credit of those companies, the Medical Society's outreach to them has been a good partnership, and they have shown that flexibility. The Bureau of Insurance on the healthcare side of things has been reaching out to the health insurers, and one of the requests that we had discussed with them dealt with prior authorization. We had seen action taken by the Bureau of Insurance in Georgia that brought relief to prior authorization, and I know that there has been steps made by the commercial insurers and even by Medicaid to try to give some relief in that regard. And the other thing, in situations where you have to have a signed physician order, I know that there is a effort underway to make sure that those orders could be either oral orders or electronic orders. So again, you're minimizing paper moving back and forth and interaction with people. So the Bureau of Insurance here has been engaged and has been frequently updating us.
I'm going to pause and just tell the listeners there's the chat function. I'm getting a couple questions, and we'll try to direct Scott to those. Scott, what do we expect from the General Assembly in a special session on April 22nd?
Well, I think the first thing is a lot of people have asked, are we going to have the reconvene session to address amendments and vetoes by the governor? And our Constitution requires that we have that 6 weeks after the General Assembly ends. So I don't believe there's going to be any constitutional waiver of it. What it's going to look like is to be determined. It could be that the General Assembly convenes and only legislators and essential staff are permitted to be in the Capitol, and the Capitol and the Pocahontas building could be closed to the public. I think the governor is really wrestling with the projection. Secretary Lane, our Secretary of Finance, is projecting that for the fiscal year that we are in, that will end June 30th, that we could face as much as $1 billion shortfall in one next year. And as you know, we have to have a balanced budget in Virginia. We can't spend like they can in Congress. And I think the governor's got some very tough decisions on the legislative front, and in front of him, he's looking at legislation that has various price tags. One example is there was legislation passed to permit local governments to engage in collective bargaining. And some of the local governments have come back to him now to say, please delay that, don't sign it into law because it will cost money. Other people have commented on the legislation that passed that would increase the minimum wage. They've come back to say at this point in time, do not pass that. And I think the other issue the governor is wrestling with is the pay increase for a lot of our state employees is roughly $600 million. And the governor is looking at that to see if that has to be pushed off or delayed. So he's got some very difficult decisions, but he'll make those and they'll get addressed. And I think the second piece that he will be wrestling with is the increased federal FMAP money coming down. How that will be spent and where that will be spent, because everybody is reaching their hand out to get a part of that. And then the final question, we have got significant funds in our rainy day fund, our reserve fund, and fortunately we do. I am sure that there will be consideration of appropriating some of those funds at the veto session through an amendment or certainly later. The next question that the governor is going to be, does he think we need a special session to address COVID-19? And if so, when does he think that's needed? So he's got a lot on his plate and he's doing a good job of trying to keep the balls in the air.
Let me ask you, Scott, one of the questions coming in is if providers do not have enough PPE, are the providers mandated to provide urgent care to a patient? What is the provider's liability? And can the hospital force physicians to provide care without adequate PPE? Sorry, complicated question.
Yeah, that's a lot of different issues there. I think that's it's one no clear answer. And I think you just got to look at the considerations of always take the approach, do the best you can with what you have. And if you always view that your actions, if liability arises, is going to be judged by a jury is going to be looking at you as a healthcare provider and saying, did you act the way that I would want you to if I, as a juror, was your patient in that situation? And it's huge struggles with PPE. It's no question. And I've seen a lot of clips and stuff that's on social media regarding appropriate reuse or inappropriate reuse or how that can be done. And I think that's going to continue to be sorted out. But there is no clear legal answer as to what's right and what's wrong.
Thanks, Scott. Another caller asks, why is there not complete immunity for a physician during this extreme and unprecedented period?
Well, I can tell you a lot of folks would love to see that. I just don't know that that is something that could come forward. I know that some have advocated that during a time of COVID-19 or anything that there ought to be blanket immunity for everything, whether it relates to COVID-19 or not. And many would like to see that. I think the practical side of it is if the governor in various states is willing to do that, or in some states it's the mayor that would make those determinations. But that certainly can be something for discussion in the future. It hadn't happened, but I don't know that anybody in recent memory can recall us being in these times. So I would imagine it will be something for consideration for the future General Assemblies.
Thanks, Scott. Next, Karen, are you on the call? Sorry, small warning to unmute.
I'm here. Sorry, it took me a minute to find the unmute button.
Karen, thank you so much for joining us again. This is Karen Remley from the Department of VDH. So Karen, tell us, what have you been working on at VDH?
Sure. Well, I officially start today. But as Clifford knows, we've started working on things kind of starting this weekend. And first, I want to stop and just say thank you to everybody on the phone. And I feel like I'm talking to a lot of old friends and colleagues who we did so much work together through my time as commissioner, but also as a clinician in the community. And one thing I would say to start off with is H1N1 was very different than this, but in many ways were similar. And one of the most important ways that it was similar is Virginia took the lead, I think, in having its clinicians around the state come together, become a team, and really take care of patients and then get the vaccination campaign out and going quickly. And I know it's that same strength of the clinician community that will get us through this. My role is to be determined, but more importantly right now to work very closely with Clifford, with MSV, with hospitals, with primary care providers, urgent care, areas to think about how do we best use our physician workforce, enabling all to be able, and nurses to do what they can do. And as Clifford will tell you, we've been on phone calls with critical care doctors last night, getting their insight and input. I'll be talking with the OBGYNs tomorrow to think about how do we make sure that we've got some semblance of continuity in how we as clinicians think about how we want to care for these patients, so that clinicians who are at the bedside have input across the state for what's going on.
Thanks, Karen. So one of the questions that's coming across is, how can private practice physicians contribute to the response plan?
That's a wonderful question. So I think there are a number of ways. Right now, sign up for the Medical Reserve Corps. Signing up doesn't do anything other than putting your name and your information in a collective database that we'll know is there. And then we're also working, I think right now there are local, Clifford and I learned yesterday, around the state, local health systems are starting to reach out into the private community to think about, can they play a role in as care sites change in what we do. But I think the other very important things that I'm hoping everybody's doing in private practice right now or in the private community is using telemedicine. If you don't have it, you can go to matrc.org, matrc.org. And I also think the webinar from last week that MSV hosted is on the MSV website. It walks you through how to link up to telemedicine. It is a way to see your patients, to maintain that continuity, to provide them quality care without having to have them come into your office and expose themselves or you. It gives us an opportunity to debulk the emergency departments because those patients can, again, talk with you. And I think also very importantly, and I know that you all know this better than me, for patients that have chronic problems, those chronic problems didn't stop when COVID came. So how we continue to provide care and that continuity during this very difficult time. It's really, telemedicine is sort of our biggest way to be able to do that. And I am not an expert on billing and coding, but I know there's a lot of work that's being done in that area too.
Thanks, Karen. So can you just, what hurdles have you seen in trying to create a surge plan for Virginia?
I think the things that make Virginia special, our geography, our differences in healthcare systems across, we've got multiple different healthcare systems that are engaged and involved. They have their own plans. And so one of my roles, along with my partner, Dr. Deal, is to sort of learn from all of the health systems what they are doing, what their plans include. And just like politics, all surge plans are local because it depends upon who you have in your community and what you can do. But cross-pollinating and learning from those various health systems, what's working and what's not. Especially, for example, we know that in the eastern side of the state and in the northern part of the state, they're surging up faster, as we know that the COVID disease will hit our regions at different times.
So, Karen, one of our callers on the line is asking if we sign up for the Medical Reserve Corps, is it mandatory at the time that you get a call?
Absolutely not. The Medical Reserve Corps is volunteer. And so it is just, right now it's obtaining a list of people who would be interested in volunteering. I'd get your name out there, but I also think in the near future, we're talking, we're talking in terms of days and weeks right now, because this is moving so rapidly. There will be other opportunities for physicians who are practicing active in their communities to be able to participate in other ways. What those are right now, we haven't been able to define. I think we are, as the health department, trying to learn, again, best practices. If you go up to ANOVA, many different physicians are retraining and relearning and kind of being redeployed in different settings than they're used to. I'd say two things. Protect yourself. So if you're a physician over the age of 65 or you have chronic medical conditions that make you high risk, think about where your skill sets could be best used. Think about what your daily skill sets are and what you do and how you might be deployed in a different way. And then I would encourage every physician to go to the MSV website and read about COVID. If you think you may be in a hospital setting, make sure, or if you are currently in a hospital, go to the Society of Critical Care Medicine. They have a number of modules specifically about COVID. And for everyone, if you have a specialty society beyond MSV, look on their websites for new COVID information about treating and caring for patients. In this time where we're kind of have a lot of angst and are waiting, it's a good opportunity to really learn and get yourself really up to speed where you need to be.
Thanks. That's a great segue. So one of the callers was asking, what are some resources where, if you're not an acute care physician, that we could go to get trained up a little bit? And you mentioned the Society of Critical Care Medicine, which has their own website, and you can register for that. There are 13 different modules that range anywhere from specifics of ventilator management to how do you expand an ICU, and we will have that link on the MSV website this afternoon.
And in addition, Clifford, American College of Physicians, ACP, also has a very good free, these are all free. All of the societies have made access to all of this information open to anyone. American College of Physicians also has a long series of modules on COVID that are more inpatient and outpatient based. I do know that if you are a member of ACP, you also get MOC credit for that.
Thanks, Karen. One of another callers asks, are PAs eligible for the Medical Reserve Corps given their collaborative agreements?
Absolutely. PAs are eligible, CRNAs, if you have people who are, nurses, assistants, front office staff. Imagine if you're trying to bring up an alternative site facility, there are multiple different people with multiple different skills that are needed, respiratory therapists. So you can imagine, and this is really a way for us to get people on board, validate that, your license is your license, you are who you are, and have that list available. And then really that's kind of the first step, I think I would say, is to get your name on that list, in addition to kind of train yourself up with the information you need, and then be ready. Thanks
for that last question, Kathy. So there's another question. Actually, a couple people asked me this today, Karen. COVID-19 information is just all over the place, and given the national press conferences, and where is there a single or maybe two best repositories of information about COVID that you would recommend in terms of clinical management? So I would say two things. One is for public health data, obviously the CDC and VDH. And a lot of VDH are links to the CDC. That's where if you want to know what's going on in the state right now from a bigger, broader population health. In terms of clinical information, I have looked, again, I would go back to the Society for SCCM, I'd go to ACP, I'd go to the MSV website. That's where you're going to get the clinical information. I do also think, as MSV and I work to bring together clinicians, because this is such a rapidly changing situation. We were on a phone call last night where intensivists from around the state were talking about different ways they were approaching their critically ill patients. So how we have an opportunity within our community to share information. They were talking about what people had done in Italy, what was working in New York, and sharing that in Virginia. I think that's one of the strengths of having this relationship and having MSV be involved, is to get those clinicians together to have those conversations real time. So that's most of my questions, and I don't want to drag the webinar out for an hour. If that's everything, again, if there are any other questions, you can please use the chat function on your browser. Scott, this question, just to go back to you, to give you a minute to unmute. A lot of physicians, if you're not credentialed in the hospital and somebody calls you to go see a COVID patient for something, and you refuse to go, can you address the medical legal consequences of that? Maybe if you are credentialed and if you are not.
Sure. I think the first thing you have to determine in that fact pattern is this an existing patient of yours, or are you on call? And if you are on call, I would assume you've already been credentialed. But let's assume what's intended in this fact pattern is this is not your patient, you're not on call, and you're just someone in the community that's well respected, and you get contacted by the ER physician or a hospitalist to come into a hospital to see a patient. You would first have to ask yourself, do you have courtesy privileges to go in? And if the answer is no, then a lot of the hospitals will have what they call disaster credentialing, and there's a process for an expedited credentialing, and one of those two immunity statutes that I mentioned actually provides some credentialing protection to the hospital as they go through that, but it's a very expedited process. And so I would make sure that would be your first step to be able to respond, so you can quickly get through that credentialing piece. And then the decision is going to be whether you have to answer that call to go or not. If it is not your patient and you're not on call, then you don't have a physician-patient relationship with that individual. So if you chose not to go, I think it's going to be very hard for a plaintiff's attorney to prove an abandonment claim against you. And I think the decision of whether you go or not is going to be one of ethics and one of a personal choice. But back to what Dr. Remley said, if there's an opportunity where you could use telemedicine to provide your advice, that may be the thing. I would assume most physicians would be hesitant to go for fear of personal contamination or fear of other cross-contamination. And so back to what Dr. Remley said, if you can help out through telemedicine, that would certainly be a way to consider.
Well, one thing I'm just going to mention, and Karen, feel free to jump in. You know, we've talked to some degree about protect the force, protect the healthcare workers to some degree. And although everybody probably wants to volunteer and be involved, folks, you know, one of my good friends is going through chemotherapy for colorectal cancer. And during that time, he's clearly immunosuppressed, and he's older and has some other medical comorbidities. And he might not be the best person to expand a COVID ICU.
So, yeah, what I would say there is he might be a wonderful person to be able to do telemedicine. And I think what we all need to be thinking about as we think about telemedicine is every time you do telemedicine, if you can do it and provide quality, safe care, you know, some of you may know I have a husband who's a cardiologist. Some of his even in the hospital, some of his consults now are through an iPad to the patient in another room if somebody else has just examined them. And one of the reasons to consider that, if it's good quality of care, you're also not using PPE unnecessarily. So making sure that when you're at the patient's bedside who has COVID, you're there for all the right reasons, and it has to be a person-to-person close contact. If there's ability to use telemedicine, you're saving not only your exposure to the patient's exposure to you, but you're saving PPE for the next patient who you really need to have that. And so I think that's, again, Clifford and I were on a call and they were talking about in one of the hospitals, they have a rapid strike intubation team because they already have all the PPE. They're all ready. They can go in and they can do it and they can come back out rather than having 20 people all put on new PPE to go in. So I think there's a lot of innovative solutions going on and people thinking about how we use this scarce resource the best we can. I made a note. I don't think there is a way in the Medical Reserve Corps to be able to right now identify that maybe you'd like to be doing you select yourself to do remote medicine, but not boots on the ground. But I will work with Medical Reserve Corps and see if we can make that a possibility, because we know we have a lot of incredibly thoughtful, competent clinicians who are over 65, and it doesn't make sense to put them in an ICU. And so how do we best, it's all about, and I think, Cliff, you probably know how to say this better than me, but it's all about in the military, how do you deploy the right resources at the right time with the right equipment, and that's what we're all trying so hard to do.
Thanks, Karen. So I'm getting a couple questions, so I'll throw this out. This might be to Scott, but I think it's to Karen that folks are asking just to review the guidelines for coding for telehealth billing.
So the coding for telehealth billing, I think, and I have not watched the MSV webinar completely, but I think there's a lot of guidelines in there. Again, I think we can link on the MSV website to it's matrc.org. That's our Mid-Atlantic Telehealth organization. And Kathy Wibberly, many of you may know, can answer a lot of those questions. I'm also going to be making the suggestion today on the telehealth subcommittee that we include someone to represent the private health plans, so we understand not only what Medicaid and Medicare will be covering, but see what the private health plans are doing and make sure that we're aligning all that work.
Dr. Deal, this is Scott. I would just add too, as mentioned, the Medical Society has gotten an update from last night where the coding practices for Medicare have been clarified, and that will be posted on the MSV site. And I couldn't agree more with Dr. Remley. This is very much a recipe book that you need to make sure you go in, and we've got resources there from the commercial market, from Anthem and others, and also from Medicaid. And so if you need help with those resources and have questions after you look at them, please let us know. We'll try to help you navigate those.
Thanks, Scott. I continue to get comments on a day-to-day basis, but even on this webinar, that some private insurers, without mentioning any names, are still not covering telehealth. We have heard across the state that a number of plans have hopped onto this, but what I wonder, this is a staff question, if there's a way we can send in or socially shame the payers that are not participating. Clearly, DMAS and Medicare have done a great job stepping up and leading the way, but I'm still hearing folks saying that they're having trouble getting the private insurers to cover telehealth.
Yes, sir, Dr. Deal. This is Scott. I will tell you that we would encourage, when providers run into challenges with commercial payers, to outreach to the medical society. We in turn outreach to our contacts at the commercial companies, and it's very essential to be able to run it to ground, to know not only the patient's name and the carrier, but also have the policy number, because you may think that it's Aetna, but Aetna may be the third-party administrator, and it's really some type of ERISA plan. And so being able to run those to ground to figure out why you're having a barrier. It could be one, that somebody in the field is not handling that correctly, or it could be they've made a mistake, or it could be that word hadn't gotten to them, but we will do our best to try to help you navigate solutions with the commercial plans. We had extensive outreach last week with Anthem, and they provided some good resources for us to get back out to folks, and that was helpful, and they have reiterated their willingness to help troubleshoot and work with us. And so we can only do it if you give us the specific examples and that level of detail: patient name, carrier, the policy number. That's what we need in order to pass it on to the carriers to run it around.
So the link to that is on the MSV website, which is msv.org/telehealth coverage. If you're having issues, and then we collect those up as your organization and on your behalf, and try to figure out if there's some way we can solve that.
And this is Karen. Certainly, if there are common themes, we're happy to go with you to talk to the health plans about how important this is for the health of the community right now. And really, it's another mitigation lever. So making sure that, that we are not having any barriers to the ability for people to social distance.
Absolutely. If you're not covering telehealth, you are putting the lives of Virginians at risk by requiring them to go to an in-person visit, which is completely inappropriate in the current COVID setting. So, Clark, let me jump to you and see if there's some other things that we haven't covered that some listeners might be interested in.
Yes, good morning, everyone. This is Clark Barano, VP of Government Affairs for the Medical Society. Thank you, Scott and Karen, for being on the call today. Notably, I think the main thing I would like to plug is that if you are having issues in this new world that we're all dealing with, please reach out to the Medical Society. Scott put in a great plug, but we've done a tremendous amount of research and organization on msv.org/COVID-19 of all the relevant information that we can find and coalesce around. Karen rightfully said that there are a lot of places with a lot of information, and we're just trying to be a clearinghouse for that. Notably, if you do run into issues with insurers or DMAS or Medicare or anybody anywhere, we are happy and always happy to be an advocate for our membership. So please do reach out to the Medical Society. We have forms on our webpage for specific issues, or you can always email government affairs, GOVT affairs @msv.org.
Okay, thanks for that, Clark. I will tell you that the Medical Society during COVID-19 is really focused on three things. The one issue is to help the clinicians of the Commonwealth guide the clinical decisions for the Commonwealth. Number two is to act, as Clark said, as a clearing house for information out to the membership. And then number three, to focus on, particularly for private practice, but across the health systems, of how can we do the other back office thing to protect your practices. And those include and some of those resources are on the website. Small business loans. I talked to one of the leaders of one of the large multi-specialty groups in Richmond last night. There's a first loan application for a disaster loan that's due tomorrow, or it can be submitted as early as tomorrow, what they're doing about telehealth. And it's our job to help get those resources to help keep your practices as viable during this time of crisis. So I think that is, hey, Larry, it's msv.org -telehealth or COVID-19 or telemedicine coverage, I think, are the website's links. So that's going to, it seems like the questions are phasing down. So anybody else, Scott, closing remarks, or Karen or Clark?
No, sir.
So this is Karen. I don't have a VDH email yet, but my Gmail is kremley, REMLEY, MD@gmail. If you've got an innovative idea or a specific question to your locality about connecting, I'm listening and learning every day. And I know I'll have a really full inbox, but it would be very valuable, and I'm willing and very able to try and reach out to you, talk about what we can do. Also through the MSV, any ideas you have. I have a feeling that Cliff and I are going to be talking to each other every day for quite a while. And I think what I would say foremost is what you just said, is how do we make sure that as we gear up for this historic event, that the clinicians of the state are able to perform the best they can, be protected, and be a vibrant workforce at the end of this event too.
All right, so that is going to conclude our call. We will plan to probably have another one next week. Thank you all very much for joining us this morning. Good luck, be well, and wash your hands.